I'm Daniel. I'm the policy officer for the Co-operative Party. I'm delighted to welcome you this evening to this evening's event on health policy and our policy process. This year, the Co-operative Party's policy process will focus on both international development and health policy. Due to unprecedented pressures from COVID, Brexit and austerity, the party felt it was really important to review and assess our health policy. Our policy process is member-led, and we want to hear from everyone on this call and from all our members and party branches. Tonight, we want to encourage everyone to make submissions to our policy process by having our expert speakers discuss the challenges which the healthcare system currently faces. Before I introduce the speakers for this evening, I just want to run through some quick tips on how we can make this more interactive and accessible for everyone. Firstly, for those who are hard of hearing, we are working with the RNID to live caption this event. If you want to view these captions, you need to enable them yourself by pressing the CC icon on the bottom tools panel of your phone or computer. This Zoom call is being recorded as many of our members can't access it live. As such, we'll be putting it on the Co-operative Party's YouTube channel. So if you don't want your image seen, please remove yourself from video and just go to audio only. Finally, in order to prevent disruptions, we'll have only those speaking with their sound enabled. After we've heard from tonight's speakers, we'll hold a Q&A session, and there are two ways you can ask a question. The first is by popping any question or comment you have in the chat box, and that will be moderated. And the second is by raising your hand, and we'll come to you when it's your turn to speak. Finally, please do bear in mind the cooperative values and principles when making contributions, so everyone feels welcome and respected. Now I'd like to introduce our two speakers for this evening, Rachel Hutchins, a fellow at the Nuffield Trust, and Mo Girash, the author of Power to the People, The Mutual Future for the NHS, a former CEO of the South London Doctors Cooperative, and also currently a professor at the University of Buckingham. So without further ado, I'll pass over to Rachel.
Thank you very much, Daniel. I'm just going to share my screen because I've got some slides. Okay, I hope you can all see my slideshow. Okay, a quick thumbs up. Brilliant. And hope you can all hear me okay. So thank you very much for inviting me to speak today. As Daniel mentioned, my name's Rachel and I work for an organisation called the Nuffield Trust. We are an independent health and social care policy and research organisation or think tank. So we conduct research and policy analysis on lots of different healthcare issues facing the country. I'm going to talk to you today about some of the key challenges that are facing the NHS, and I've been asked to speak on a couple of specific topics. So I'm just going to run through sort of, I guess, where we're at and some of those key challenges. Great. So I think, firstly, obviously, the COVID-19 pandemic has had a huge impact on healthcare systems in this country, but also around the world. And we know that the NHS at the moment is facing challenges in the kind of aftermath or wake of the pandemic. I think it's worth saying that a lot of the challenges aren't necessarily new. So a lot of these challenges were things that were issues prior to the pandemic. But what we've seen is that the pandemic's put additional pressure on these issues and also in many ways exacerbated them. I think it's worth saying that looking internationally, which we've done with some particular research, you can see that a lot of other countries had shared experiences, shared challenges, and are adopting similar approaches to try and deal with the way the pandemic has impacted their healthcare systems. But what we know is that the UK entered the crisis already with challenges. So fewer doctors and nurses, high bed occupancy rates. We already had waiting lists rising prior to the pandemic. And I think that that shows that the NHS was already under a lot of pressure before the pandemic happened. I think in terms of the sort of public attitudes around the NHS, we know that according to the British Social Attitude Survey, that last year, overall satisfaction with the NHS fell to 36%, and that's the lowest level recorded since 1997. So we've got a combination of the impact of the pandemic on services, but also staff and public expectations as well. As I've just touched on, I think one of the particular challenges we can see at the moment is around waiting times and performance. And you might have seen in the news stories about the number of people waiting for treatment and care. So the survey that I just mentioned about satisfaction, the main reason that people gave for being dissatisfied with the NHS overall was waiting times for both GP and hospital appointments. So 65% of people who responded gave that as a key reason. We know that there's a huge amount of pressure on all aspects of NHS healthcare. We've looked specifically at pressure on children and young people's mental health services, for example. And we saw that in the period between April and September 2021, there were 81% more referrals for children and young people's mental health services than the same period the year before. So we're really seeing a huge amount of pressure on services. And this is also having an impact on performance. So in April of this year, 28% of people attending A&E spent more than 4 hours from arrival to admission, transfer or discharge. We've seen really high numbers of people waiting over 12 hours. So that's people sort of referring to things like trolley waits. And also in April, 1 in 10 patients waiting almost 2 hours for an ambulance. So we can see the sort of challenges. And the waiting list for people waiting to start planned care rose to 6.36 million, which is the highest since records began. And you can see in the chart on the slide the increase there. So we know that there's a huge pressure on waiting times. Another area of challenge is around workforce. So when we talk about workforce, we're referring to pretty much everybody who sort of works for the NHS. So whether that's sort of doctors, healthcare staff and nurses as well. And again, I think it's worth saying that this was a long-standing and quite widespread challenge that was something we came into the pandemic with. So a challenge kind of both recruiting staff to work in the NHS, but also retaining staff. So making sure, or people staying working within the NHS. Even though this is a national challenge, we know there's also wide variation across the country. So the map on the screen, if you can see it, shows the number of patients per GP. So it's sort of showing, I guess, the distribution or concentration of GPs across the country. And you can see that there's variation, and this is weighted according to the needs of the local population as well. The survey that I mentioned, the second most common reason for low satisfaction was workforce shortages. So this is obviously something that's at the forefront of people's mind as well. But it's not just workforce, I guess, numbers. We know that we've got huge pressure on the NHS workforce from the impact of the pandemic, issues around stress and burnout. The most recent staff survey of NHS staff showed that almost 50% of staff have felt unwell as a result of work-related stress in the 12 months up to the survey. And I think it's worth saying that number had been increasing over the last 4 years. So prior to the pandemic, this was already a challenge. We know that within the workforce as well, we've got challenges around the need to increase diversity and inclusivity as well, and actually really be clear on what our workforce needs at different points across the country. So again, this is a long-standing challenge, but I think that one we're acutely aware of at the moment. I also wanted to touch on health inequalities, which is another thing that I think has been, in a way, put in the spotlight or highlighted in some ways by the pandemic, but is again something that isn't necessarily new. So what I refer to when I mean what I'm referring to when I say health inequalities is the definition I've used on the slide is unavoidable and unfair differences in health status between groups of people and communities. And I think we often see this when discussing discrepancies in things like life expectancy in different parts of the country. But we also know that there's evidence that people experience inequality when they're accessing healthcare services and in the quality of care as well. Our analysis has looked at, for example, the care by deprivation, and we saw that in more deprived areas of England, there was evidence of people experiencing a poorer quality of care across lots of different measures. So we know that there's a lot of different factors that influence that. And I think in terms of what we've seen in the pandemic, what we're conscious of is also things that might risk exacerbating that inequality. So, for example, we've seen an increase during the pandemic in the use of digital technology and remote care. So, for example, online or telephone GP appointments. And while that's been beneficial in some ways because it can help people access services, we also need to make sure that that's not actually excluding people. And there is some suggestion that increased use of digital technology might result in a digital inverse care law. And what this means is the people who are most in need of care are actually most likely to miss out on those digital opportunities. And given the challenges facing the NHS, I think it's really important that any of the initiatives put in place to address those are also very conscious of not exacerbating those existing health inequalities. And then finally, I was asked to touch on the Health and Care Act. So this is a piece of legislation that received royal assent, I think in April this year. And essentially the aim is to provide a legal framework to support greater collaboration and partnership working across the NHS with the aim of supporting integrated care. So where services are joined up to really deliver the needs of patients. And obviously the Act itself is quite complex. There's lots of different provisions in it, but I just picked out a couple, which is essentially the kind of legal provides a legal basis for integrated care systems who will be responsible for commissioning services within their area. We don't see that increased privatisation is a likely effect of the bill. The changes seem to herald a move away from competition to actually a greater focus on collaboration. But obviously, as I say, there are lots of complex challenges there. And I think it's also important to flag that the Health and Care Act doesn't necessarily address a lot of the issues facing the NHS more widely, and things like workforce health inequalities I've already mentioned. We know that social care as well is a huge challenge, which sort of goes hand in hand with the NHS as well, I think. So I think a lot of these issues, as I say, have been potentially highlighted by or exacerbated by the pandemic, but a lot of them are also long-standing challenges as well. So I hope that that's been helpful to give a little bit of context around some of the issues facing the NHS, and I look forward to the discussion.
Fantastic. Thank you very much, Rachel. That was really great. I'm going to pass over now to Mo. So I think Izzy will help. Is going to share the screen, and we'll go through the presentation from there.
Thank you very much indeed, Daniel and Izzy, for inviting me. I'm absolutely delighted. So good evening. It's a privilege and honor to be invited. I've been involved in Co-op Party in my young days, but also involved in Co-op for over 35 years. Today, I want to share with you my personal observation, thoughts, and experience of working within a health co-op. Being a clinician, I got into that, and it's been a great success. So let me just give you an observation. So I've been working in co-op, health co-ops for 25 years. I started working at CellDoc, South East London Doctors Co-operative. We started with 50 doctors and grew it to 500. We set up 4 subsidiary businesses, which was most successful. Waiting times were short. We had a one-stop shop. We did home visiting. We had a huge flexibility in how we provided our care. We had freedom of how we employed our staff, what we paid. And of course, one of the things Rachel mentioned were some of the challenges around NHS. One of them was around staffing. And it was an organization where I'm sure you've all come across GP co-ops. This is a service which is provided to your families and yourselves after the surgeries are closed. CellDoc served patients, employees, with the flexibility of how we paid our staff, including bonuses, and also GPs who took in turns to provide care, so they were not overloaded with workload on every night shifts. They took it in turn. And we had a very good kind of arrangements with over 500 GPs who took it in turns and shifts, which it included bank holidays and otherwise. And of course, GPs were paid for the work as part of that. In terms of some thoughts and observation, I've spoken locally and national on health corps that include Spain, Canada, and Japan, and I'll share some observations with you in my talks. So, Lizzie, could I have my first slide, please? I'm most grateful. Thank you for that. Second, so I'm going to give you some observations around why health cooperatives are a reliable enterprise model of delivering healthcare, and more so with Rachel giving us some real challenges in healthcare, both in terms of service delivery, health inequalities, staff recruitment, and so on. Thank you. Can I have the second slide, please? So what I want to give you is my thoughts and observations on the global overview of health cooperatives. I'm sure cooperatives, I'm sure you're aware of cooperatives is international phenomena, but I want to talk about some benefits, some challenges, some examples, and the case for healthcare in England, and what's happened to GP Corps and where we are with that. Thank you. Can I have my next slide, please? So health corps, there are around 100 billion households who enjoy access to healthcare via health cooperatives. That's a phenomenal large number. In 76 countries, with registered 3,300 health cooperatives with an overall turnover of $15 billion. And that's a huge amount of money within the national economy to consider. The health cooperatives include organizations with range from origins and structures, whether they're doctors' cooperatives, which I ran, which you're aware of. And of course, in Spain, you've got health cooperative hospitals providing healthcare. 70% of the healthcare in Spain is run by health cooperatives, including Brazil. Healthcare facilities, institutions, health promotion, staff training, and otherwise. And of course, in some countries, you've got co-ops, which are pharmaceutical-led cooperatives, including health insurance, which you're aware of. And I'm not going to get into that dynamics of cooperative health insurance. Thank you. Could I have the next slide, please? So what are the benefits of health cooperatives, which I have realized in health domain? And I'm sure you've come across social enterprise, mutuals, and all of that. There's different definitions in terms of what they are and the outputs. But for me, having worked in health cooperatives, the benefits are ability to innovate, adopt, and it's also about the relationship with members and ownership of the organization, which allows the organization to benefit on an ongoing basis. But also, I think one of the benefits of co-ops is around how it fills the gaps in competing local health environment, where people then say, we're going to pick up this gap and we're going to work together to deliver that gap in line with other providers. And why are health cooperatives successful or not successful? I'll share some thoughts and observations on that. The other thing about cooperatives is they prioritize the needs of the stakeholder groups, the specific in terms of moving forward around accessibility and specific around population groups. And Rachel looked about inequality, and this is also about whether there's a gap in how there's equality of care for local population. And I believe in for the people, by the people. And the paper I've written around Power to People talks about some of the dimensions around that. The thing about health cooperatives can adjust to economic, social, and political conditions more rapidly because it's owned by local people and it has got its own infrastructure without being pulled by different political dimensions and or otherwise. And it's run by the people for the people. So I think it's very important how that's aligned to the surrounding cultural, socio-economic environment, and that's very powerful. Thank you. Next slide, please. So, of course, health cooperatives, like any business, it's a business. It is a business because it has to make money to survive, to reinvest. But it's how it's managed and what are the outputs. Of course, it has got challenges. And one of them is procurement tendering of contracts. We don't have time to spend lots of money into tendering contracts and procurement. And I know there's been some changes around that. And maybe, Rachel, you can give some dimensions around that, where I think some of the third sector organizations, including co-ops, are given opportunities around the thing called the Social Value Act, which is very important. And I suggest you look at that. Social Value Act is very important, and they become instrumental around procurement. Sometimes there's a lack of governance, trust, and decision-making, and that linked to having senior skilled staff who can manage that kind of corporate governance issues. Sometimes, of course, there's control is always an issue about operational control, accountability, and how do we, it's all very well setting up a health co-op, but it's about how do we actively involve local members, both in decision-making processes, but also in active involvement. And that's a challenge because sometimes you may not have that. And the other challenge is it's a business, so we have to make surplus to reinvest, which is very important. And of course, we have to be responsive to market competition. And there's also a challenge about collective ownership, which I talked about in terms of active involvement with local members. Having said that, I think one of the benefits of also, I just want to share this, the benefit of co-ops is ability to innovate continuously, ability to allow staff in decision-making processes, ability to pay my staff the rate I want to pay, which allows me on the economics of the organization, bonus payments, recruitment of skilled staff, if that's the case. So it's both a challenge, but also benefit. Thank you. Next slide, please. I don't know whether you're aware of health co-ops, but I've talked about GP out of hours co-ops, which is a very good example. And I worked at CellDoc, South East London Doctors Cooperative, and also worked at the Partnership of East London Cooperatives many years ago, and I've left them. Co-ops are present in the health sector in many countries. In Argentina, for example, they engage in primary care, nursing, pharmaceutical services, and nearly 50% of the population have no access to healthcare. And of course, that allows that benefits coming in. Australia has got a GP working together co-ops. Brazil has got a Unimed. It's the largest healthcare network around. Belgium has got a pharmaceutical industry. Spain has got huge health cooperatives, including hospitals, health cooperative hospitals. I spent a whole week in there. The decision-making processes, the quality of care, the governance, the active involvement of staff, the patients was phenomenal. Canada has got ambulance co-ops, surprise, surprise. Japan has got 2.9 million GP co-ops. I spent some time there, particularly in the nursing home, which was run by health co-ops for elderly care. Fascinating. Singapore, Italy, Lesotho, and Rwanda has got a health co-op around HIV and AIDS healthcare, surprisingly, and they're doing extremely well. I just wanted to give you a dimension of the health cooperatives in the world where there's a huge success. They're doing really well. They've been looked after by marginalized population, and so on and so forth. Thank you. Can I have my next slide, please? So I've just suggested, these are my thoughts, because it's very easy to talk about health cooperatives. And I've been talking about health cooperatives for 35 years, and we're still talking about it. So I'm really excited about it when I was at a phone call saying, we're here, it's great. So just this thought. Next steps for me would be to do a stock take to where we are with GP co-ops and why they're disappearing and becoming social enterprises. Suggest that somebody really worthwhile going out and doing a kind of stock take, or whatever you want to call it, visiting different countries and finding out why they're successful, which areas in healthcare they've been really made a big difference in making a significant change in population health and indeed public health, but also where their failures and how they may be managing that. And of course, sometimes with anything, when GP co-ops first started, the government did give seed funding to create GP co-ops. And I suggest we do the same. Somebody does it. We do pilots, evaluate from stakeholders' perspective, patients and NHS. And the timing can never be right for health co-ops with the new white paper and some of the kind of challenges outlined by Rachel. Those are my thoughts, my observation, based on my experience of running a health co-op, but also talking to international audiences around it. So thank you very much indeed. I'm most grateful for having me, and I'll be very happy to take questions, not that I've got all the answers. Thank you.
Thanks very much, Mo. That was a fantastic presentation and covered a really good range of facts and information on co-ops across the globe. So thank you. As we move into the Q&A session, I'll aim to take about 3 questions each time, and then we'll pass them back over to Mo and Rachel to answer. So to begin with, I see Norman has got his hand up. Would you like to come in, Norman?
You need to mute.
I think you're unmuted now.
Okay, thank you. Thanks very much, Dan. Yes. I divide my time, well, for the last 10 years, I've divided my time between living in England and in Portugal. And I'm registered with GPs in both countries. So this gives me a good opportunity to see how the 2 systems run. One of the biggest differences I've noticed is in the attitude towards preventative medicine. I see my GP here in Lisbon twice a year, and each time she sees me for about 3/4 of an hour, going very detailed examination of various possible things that might be coming along. And there's always automatic blood tests, extensive blood tests for this. This compares with, in England, in Derbyshire, where I also see my local GP. If I try to get appointments there for checkups, I usually just get passed off to a sister who usually sees me for about 10 minutes. So there's a remarkable difference there. I did think it might be because of differences in numbers of work staff available, but I checked up on the figures, and UK and Portugal have similar numbers of qualified staff per head of population. So it's not a problem with staffing. So but my question really is, have either of our speakers researched at all the effects of preventative medicine? It would seem to me to be a pretty obvious thing to go for in terms of long-term savings of money and staff time. But is there any evidence at all that concentration on preventative medicine actually pays dividends? Thank you.
Thank you, Norman. I've got one in the chat, which I'm just going to read out, and then I'll come to Dr. Luke after that. So Janice asks, why do you consider that less competition means no extra privatization? And she's listed several health campaign groups which believe that the changes from the Health and Care Act will actually encourage greater privatization. Dr. Luke, would you like to come in?
Hi, yes, thanks, Dan. Just to sort of briefly introduce myself, some of you may know me from the Fabian Society. I sit on the national exec there. I'm also co-convener of the Fabian Health Society. And in sort of my day job, I'm the Policy and Public Affairs Officer for one of the medical royal colleges. So this is sort of literally my day job. Particularly, we look at, I'm one of the Royal Colleges of Surgeons that I work for. So we are looking in secondary, tertiary care. I noticed that everything that the 2 speakers talked about really was primary care. And I did wonder if they had any thoughts, because I struggle to see in an NHS context, rather than a context where you have insurance and sort of private or other sector involvement, how you bring cooperatives into that NHS secondary and tertiary care structures. So I just thought the panel's opinions on that would be useful.
Thanks very much, Luke. I'm going to pass back to Mo and Rachel now. I'll pass to Rachel first, and then Mo, do you want to come in after?
Yeah, thanks very much. Really helpful questions. I'll try and respond briefly to the first couple. Cooperatives in healthcare isn't something that we've researched specifically. So in terms of the last question, if it's okay, I'll hand that one back over to Mo. I think in terms of the first question around preventative medicine, I think there's definitely kind of an acknowledgement that a greater focus on prevention and also population health, so actually designing services to respond to the needs of populations, should be a really important priority for the NHS. And I think that the integrated care systems that I mentioned, the sort of emphasis on supporting the needs of the population is one of their ambitions. But I think in terms of the specific evidence about what that means for systems, I don't know off the top of my head that specifically, but I think it's a really important point, because I think what I spoke about in my presentation about those kind of long-standing challenges, I think that what that means is that the NHS has been under such huge pressure to sort of respond to those kind of issues that are happening right now, that actually you need the kind of slack in the system to also be able to respond to those more preventative issues as well. And you spoke about primary care and the challenge getting appointments, and I think we all are aware of that particular challenge that's happening in the country at the moment, and around kind of the issues facing primary care. And I think it's a kind of case of rising demand for lots of different reasons, and actually just not necessarily enough supply as well, and actually lots of challenges around sort of creating that perfect storm, really. But I think it's definitely something that should be an ambition, but it's something you need to sort of build in to the system to be able to actually sort of respond to it. And I think what's been so difficult with the pandemic is obviously creating that additional pressure on services to sort of respond to those issues in the kind of present time that we're in. I think just on the second question, briefly, I can't see the question in the chat, but I think, and my colleagues have worked a bit more specifically on this particular issue. So apologies if I don't respond particularly accurately. I think what I was trying to emphasize was that from our perspective, the issues in the health and care bill sort of signify a greater focus on cooperation between services and a move away from competition. And I guess that's kind of obviously exactly what happens. It's very complex sort of set of issues happening, but from our perspective, from the analysis that we've done, that's what we've sort of looked at. And I think that the other issues that I've mentioned around sort of inequalities in workforce are some of the kind of key overarching ones. But yeah.
Mo, would you like to come in now?
Yeah, thanks so much. So on the so I echo Rachel, but I think I just want to make a comment on preventative medicine. I think when we ran CellDoc many years ago, we used to have focus groups for patients where we did lots of preventative work. That's 25 years ago. The reason I'm saying that is when you own something owned by local people, and there's autonomy and flexibility, you can do so many things you want to do without being pulled by different things. So I'll just park it there. On the issue about competition, and again, echo what Rachel is saying, I think for me, from a co-op's perspective, I think for me, it's procurement rules and all of that has to change, because as a health co-op, for me to bid for a contract in the new world, I know the laws have been slightly laxed, and Rachel, you may come here, I'm not fully versed, please don't quote me on it, but I think there is now flexibility around procurement so that the third sector can bid for contracts particularly around Social Value Act. But I think that's very important. And on the, Dr. Davis, you made a very good observation around tertiary, and I think you're referring to acute hospitals. Now, if you look at Spain, 60% of the hospitals in Spain are run by health cooperatives, and I've spent a whole week there. And there's a paper I've written around whether the next stage for foundation hospitals would be becoming a fully fledged cooperative hospitals. Now, that my observation, this is personally, I think we should go ahead and do that, because there'll be more autonomy, more flexibility, more enhancement. There'll be flexibility around recruitment. There'll be more engagement with public, and there'll be more innovation. I'm not saying it's not happening, but I think FT, foundation hospitals, are already there, halfway to fully fledged independent co-ops. I'll stop there. Thank you.
Thank you very much, Mo. I see several people have got their hands up, so I'll come to Paul, Afflift, and I've also got one in the question box, which is from Chris Bain. So I'll ask him to read his out after Paul and Afflift.
Hi. Yeah, I think it's really interesting that the co-ops have come up into the conversation here in this policy discussion point. I think they're critically important, and I think we need to reevaluate the whole of the integrated care system approach that is currently underway. I think it's really important to emphasize, and this is a conversation piece within the integrated care system conversations that are taking place across the country, is the not-for-profit sector and the size of the not-for-profit sector and the role that it does play in well-being development and that early intervention prevention. 90% of what the not-profit sector does is it can be classed as early intervention prevention. And if you just take Devon as an example, where I live, there are 6,000 organisations operating in that space. Over almost 100,000 people are getting engaged on a paid and unpaid basis. So that's a massive resource pool that's participating in care and support of people across our communities. The problem is that we have this massive deficit of need, and that is despite that weight of work that's going on in the third sector and, of course, the public sector. So if we're going to resolve the situation, we need to find capacity and efficiency in what we're doing. And one of the fundamental problems we had in the health system, and obviously where the integrated care systems come across, is that it's been very silo driven and very singularly focused around themes, mental health or an acute care or primary care, as opposed to looking at the needs of individuals and communities. And that's something that means we need a fundamental system change if we're going to resolve that. And cooperatives is a perfect vehicle for doing that. And if we can go down that road, the other opportunity that we start to create is we start to look at the other determinants of well-being that affect health outcomes. So unemployment, deprivation, lack of housing, all those other factors that create an unhealthy population. And critically, if we're going to turn the tide on the growing deficit that we've currently got, we've got to have that early intervention well-being prevention strand of work working right alongside the ICS, which for the next 5 years, to be frank, is going to be focused on crisis resolution. And unfortunately, that is what recovery is about. It's going to be, resolving the matters of crisis that are impacting the service at the moment. So that's what I would certainly like to see in a policy process, is this engagement to look at how we establish more cooperation, however that's structured, within and across our local communities, that engages all that wealth of expertise, knowledge and capability that exists around the early intervention prevention agenda.
Thank you, Paul. Alift? Are you able to unmute? Oh, there you go.
Yes. Can you hear me now?
Yeah.
I so agree with the last speaker, because my comment is going to be made similarly. The health service cannot operate in isolation with other determinants of health. It can't. Secondly, there was always an integrated care system. What has happened, it's never been recognized. It's never been recognized, it's never been funded, and it's never been legitimized. There's no legal. But home care is care. Voluntary care is care. People-to-people care is care. Self-care is care. So throughout humanity, there has been integrated care. Can we call that commissioning rather than creating? Because I can't see anybody creating a healthcare. Commissioning, yeah. Creating it's always been there. Even the voluntary service of health operatives is 35 years old. How can you create something that's already there? That's my comment. Thank you.
Thank you. I've got a question from Chris in the chat, which refers back to a staffing point Rachel made earlier, and that is, how can we ensure that the NHS has higher rates of staff retention and prevents burnout? Because that's an absolutely critical issue we're facing at this moment in time. So I'll quickly pass back to Mo and Rachel at this point. Then if you want to come, yeah.
Okay, thank you so much. Paul, thank you so much. Paul, your comment is extremely valid, and about health and well-being, and I think engaging local communities and giving empowerment to do that are very powerful. If I give you one example of what we did 25 years ago at CellDoc in local community. So patients went through and had their cardiac surgery. A patient came and talked to us and said, we want to set up a group. We gave them a bit of funding, and they got themselves together with all the local patients who had the cardiac surgery. With no support from us, this is empowerment by local people, by giving them a little bit of seed funding. They organized a group that coffee mornings, we gave them a space at the CellDoc offices, and they did three things. One, they got together to agree exercises, supported by and inviting local people to come and give exercises. They brought in and wrote letters to different cardiac specialists to come and talk to them about things like how do they look after themselves, inviting dietetics. It's about empowering people to take and run with it, and it's very powerful. So that's the comment on I would give you just my observations, Paul, on that, and I totally agree with you. On the issue of the last, what was the last comment? Sorry, can you?
It was, how can we ensure that we retain staff more effectively?
I think Rachel is probably going to give you an observation from NHS perspective, but for me, for cooperative perspective, because you have freedoms. You've got freedom to pay the staff I want to pay, freedom about bonus, freedom about innovation. You know, there's lots of flexibilities around that, rather than guided by some of the NHS kind of agenda for change and stuff, I think. But I'm sure Rachel would have a more defined and proper answer to that, Rachel. Thank you. Many thanks.
Yeah, thanks, Mo. I can come in on that point. And I think it's a really, really important one, because when we talk about workforce and needing to address the challenges, we really are looking at all stages of that career pipeline. So not just getting people into working in the NHS, but actually thinking about why, what is going to make people stay. Some colleagues of mine recently did a bit of work, which was looking at the numbers of people who are leaving the NHS and the reasons why. And unfortunately, the data and information on that is not brilliant, but we do have some insight on some of the reasons. I think the most common reasons are things like relocation and retiring, but we have seen an increase as well in the numbers of people citing things like work-life balance or health. Other reasons as well around a lack of opportunity or, for progression, issues around pay, education and training, as well as issues of burnout and job satisfaction. So I think what that shows is that there are a huge multitude of reasons that might affect somebody's decision to leave. And I think what's really important is to actually recognise that each of those things is potentially going to need a different solution. I think obviously generally trying to address the challenges around workforce shortages is really important. And I think that what we've emphasized is, as I mentioned in my presentation, that actually, you know, it is different, the needs of different areas are different. So actually having really robust regional workforce planning that's really looking at what the needs of that population are and who the staff are that need to kind of be there is really important. We've not really had an adequate focus on long-term workforce planning in the NHS before, and I think that, you know, we're seeing the impact of that, or we have been seeing the impact of it, and it's particularly acute now with the pandemic. So I think sort of generally addressing that's really important, as well as sort of understanding how to attract people into the NHS as well. But I think what the research that I just mentioned shows is that there are a huge multitude of reasons that are really affecting those decisions to leave, and actually, you know, understanding that is, I think, the first step. What is making people make those decisions, and then sort of working from that as to how you kind of encourage them to actually stay as well. So it's probably a multifaceted approach, really.
So can I just come in and make a comment? Rachel, I agree with you. And I think one of the things with ICOs and ICSs, which have been produced, I think it'll create different opportunities for staff in terms of employment opportunities, working across different sectors with either single contract or joint contracts. So there will be creativity around how some of the roles will be formulated around whether they work in community or they'll be also working in acute hospitals, in a charity, because ICS is about working collectively within the local health economy. So I think hopefully that may help. I'm just my observation, I think. Would you agree, Rachel? Just thoughts?
Yeah, I think we've definitely sort of looked at, so in primary care, for example, talked about, you know, the variety of roles that people can do within primary care and the role of people like pharmacists and physios, not just GPs. So I think sort of looking at that, it's quite jargony, but the sort of skill mix, and actually, you know, recognising that there are a lot of people who can really sort of contribute effectively to that. And I think the earlier comment that was made around, you know, the integrated care not necessarily not being something new that's been created, but actually the focus being there for a long time. That's absolutely the case, and it's been an ambition for a long time. And the bill in some ways sort of, you know, provides that new legal framework, but actually the desire and all of the efforts that were going on to actually make that a reality is not something that's new. And I think that I would absolutely echo what's been said around the role of the voluntary sector, but also, you know, the NHS is not working on its own. And we know, as was mentioned as well, about the wider impact of the social determinants. So it's really about, you know, looking holistically at all of these factors that are going to influence sort of, you know, people's healthcare, and actually how you kind of respond to that effectively.
Thank you very much, Rachel. I'm going to come to Catherine, Pat and Paul now, who've been waiting patiently. Can I just ask that you keep your questions quite brief, just in the interests of time? Thanks very much.
Thank you, Daniel. The first thing I'd like to say is make sure that you've noticed that Saxon Spence has had her physical hand up for quite some time as well. I didn't know if you were picking that up or not. But my question, I guess, is primarily towards Rachel. And that is, one of my main concerns has been the systematic, ongoing underinvestment in the NHS. You can probably tell from my accent that I didn't grow up with an NHS, and perhaps that's why I value it so very much. My primary concern with the ICBs and their commissioning services is that can be yet one more way that you can take the situation where the NHS has had underinvestment, so it may be less well placed to deliver on something, which then leads the ICBs to commission services with a private company, and that then propagates more underinvestment in the NHS. I think we've seen this throughout COVID, where the money is going to private companies that could have gone to, like Test and Trace, to the NHS to develop the same thing, so they probably would have done it better, and we would have had investment in the NHS. And you commented that Act, the Health and Care Act, wasn't going to lead from what you could tell, to increased privatization. But I have a very strong concern about that. And I'm wondering if there's anything you can say that would make me think, oh no, the ICBs aren't potentially going to lead to greater privatization and more underinvestment in the NHS.
Hello.
Sorry.
I'm sorry. My question is going back to primary care. I think there are still people who do not realize that all GP practices are private businesses funded with public money. I hope some of them are run as co-ops. I do not know. What concerns me more at the moment is the news that one is increasingly finding out about, and that is about GP businesses, practices, being taken over by huge American health companies. There was a case in the law court about a month ago. I haven't found out what happened, where a lot of local people were campaigning to prevent their GP surgeries being taken over by an American healthcare company. I wonder if particularly you're doing any research into that. And I hope you are at Nuffield, because it's increasingly privatization in quite a vast scale, and it's very worrying.
Thanks, Pat. Sorry, Pat, I'm just going to come quickly to Saxon. Oh, she's on the phone now. I'll come to you first, then we'll go immediately to Saxon after. Thanks very much.
Thank you. Something that a lot of people, particularly with mental health conditions and other long-term conditions, find useful is peer support. And there's been the growth of peer support workers and lived experience workers, first in the voluntary, first as volunteers, then within the voluntary sector, and now more and more inside the NHS, particularly mental health trusts. I was just wondering if we could have some comment about how to take that forward. It seems to me a very cooperative idea, and it's something that some parts of the NHS are doing very well, but in others they're doing very badly and haven't got the right level of support and buy-in. But I think it does seem to be however it's delivered, seems to be quite a positive approach.
Thank you very much, Paul. And then finally, Saxon, and I'll pass back to Mo and Rachel. Sorry to keep you waiting so long. Didn't see your hand.
No, I can't find the automatic hand. Thank you very much for this presentation. I do think one of our problems is that we have an ill health service, not a well health service, and the share of resources that goes into primary care and public health does tend to get drained away into the needs of the acute sector. What I would like to ask our panel is, surely we should be looking at the cost benefits of preventing. For instance, if we could prevent older people having falls, we would save in ambulance call out, A&E, hospitalisation, and often a bad fall will lead to someone losing their independence and ending up needing residential care. And it does seem to me there's a case for a public health approach. And the other thing I'd like to say is I do think we ought to encourage all co-operators to take the opportunities that there are. For instance, the Royal Devon and Exeter is a trust to which I belong, and we can elect people to go on scrutiny committees. We get invited to meetings and to find out what's going on. And there are patient participation groups. I think we should encourage people to take these opportunities so that whatever opportunities there are to promote cooperative values, we're taking them.
Thank you very much, Saxon. I'm going to pass back to Mo and to Rachel now, so you can respond to that. And also, just in the interest of time, after that, if you could give your final thoughts as well and sum up, would be very much appreciated. So I'll pass back to Rachel.
Thank you very much. There's a lot to unpick in those questions. I'll try and be brief, but also helpful. I think just very briefly on the last one, I think absolutely we've touched on already the role of prevention, public health, and I think it's really important to emphasise the role of the social care system there as well in actually supporting people to live independently. And we've not sort of spoken about that in great detail today, but I think it's really important to actually recognise the real challenge crisis facing our social care system at the moment, and how important it is to sort of not only address that through funding, because obviously funding is a key part of it, but it's not the only solution as well. And I think that, you know, we've talked about how multiple different sectors are involved in sort of supporting people's healthcare, and I think all of those things that have been mentioned are really important. I think the challenge is that we've not necessarily had the chance to think really long term and actually think sustainably about how to make those things sustainable, because, you know, we are sort of after the pandemic at least sort of looking at the short term and trying to respond to that, and actually a longer term approach is really important. Just going back to the first question then, and again, apologies, I haven't been working on this specifically, and I don't know the real specifics of exactly how the ICBs are going to work, but from some analysis that my colleagues have done, or sort of looking at it, I think that our perspective was that, given, you know, so there's always been private sector involvement in the NHS in terms of private companies delivering NHS services and being commissioned to deliver those services. I think our perspective was that the specific changes within the bill around procurement won't necessarily lead to an increased role for private sector providers there. And I think that the issue that you've mentioned around during the COVID pandemic, I think what that's really highlighted as one of the big challenges was around transparency and accountability. And I think obviously it's hoped that any decisions that are made by the ICBs will be at least made in a much more transparent and accountable way. But I'm afraid I can't speak in sort of lots of detail about the specifics of how that would work. I'm afraid I'm just not expert enough on that. And also to answer the question about primary care, yes, I think that's a fair point actually, in terms of, you know, the way that GPs work as being private providers, and that not necessarily being known about more widely. We aren't doing research specifically, as far as I'm aware, on the specific point that was made, but we do a lot of research more generally on primary care and the kind of challenges that are facing that, and what solutions are out there. And I think that you know, we do have a big challenge there, but I'm afraid we're not doing specific research on that particular question.
I'll just come in. So just echo Rachel with everything you've said, really. Just want to make two comments. One is around the mental health and peer support. I think it's a very good idea. And I think, you know, somebody should just pick up and set up a cooperative for running a peer support adjacent to mental health services. I think it'd be a great idea. On the issue of patient participation within the hospitals, of course, there's a foundation hospital, so that'd be great. And I think I'll go further, and, you know, foundation hospitals appoint governors. So why don't you put yourself forward as governors? It may be a good way of influencing some of the thinking process and understanding what's going on. And on the issue of the last point around the preventative, it's funny, it's interesting. The theme is preventative medicine, prevention, local people involvement and all that. And that's all principles of cooperative. And so I'm really excited. The theme is still there. And I think we should enhance that.
Thank you very much. Thank you to everyone as well who's come this evening. I know there's many people out there who still have questions. I'm very, very sorry. We do have to wrap up at 7. But all I can say is very keen to hear from you on these points, and we'd be delighted if you could respond to our policy process and have your say and feed into our policy on health this year, which is of course member-led and we'll be voting on at the annual conference. I think Izzy's put the details in the chat, so, you know, any questions and any points you want to make, please do send them into the consultation, and we'd be delighted to hear from you. Thanks again to our speakers for this evening. It's been a real pleasure and really informative for us all. We're still going to be hosting these Cooperation Live events throughout the summer, And in a fortnight's time, we'll be hosting our 50 Years of Pride event. So be keen for as many of you to join as possible for that as well. Well, I hope you have a fantastic evening and a great bank holiday. Thanks very much for joining us this evening. Thanks again.
Thank you. Bye-bye.